All right, good morning, folks, and welcome to Friday Chalk Talk. My name is Martin. I will be your host for today. And today we have a discussion on prognostication in acute ischemic stroke, where we'll focus on some aspects of a recent publication in the Journal of Palliative Medicine, which is titled Clinical and Imaging Features Associated with the Utilization of Comfort Measures Only in Acute Ischemic Stroke. So today I have the pleasure of introducing two of the paper's authors. First, we have Dr. Varun Jain. Varun has a background in internal medicine, completing his residency and his chief residency at Mount Sinai Medical Center in the Bronx. And he worked as a hospitalist for 4 years. And in 2019, Varun moved over to a career in neurology, just graduated from residency, and he's currently a neuromuscular fellow at the University of Florida. Welcome, Varun.
Thank you. Good morning to everybody. And thank you for inviting me, Martin.
Absolutely. Second, we've got Dr. Nandakumar Nagarasha. Nandakumar is currently a professor of neurology at Milton Hershey Medical Center at Penn State College of Medicine. He completed his neurology residency at Wayne State University of Medicine in Detroit. He is highly published, a nationwide speaker, and a mentor to many people in the field of neurology. Welcome, Nandakumar.
Thank you, Martin, and thank you for inviting us to this platform to present our article.
Absolutely. Our format for today is going to be two parts. So the three of us have settled on 5 main topics for our initial discussion today, and then we'll open it up for the audience for some questions. So we'll jump right in. So for our first part, let's start with a brief overview of what's already known about prognostication in acute ischemic stroke prior to your guys' paper.
Yeah, Martin. So before that, I just want to say that strokes are of 2 types, and 80% of the times it is the ischemic stroke, that is the lack of blood supply or occlusion, and 15 to 20% of the strokes are hemorrhagic strokes. Now, the prognosis in both of these different strokes varies a little bit because, as per data, the 30-day mortality in the ischemic strokes is nearly like 10%. And whereas in the hemorrhagic strokes, it is more and can go as high as like 40% as per the data. Now, our paper was mostly we were studying the ischemic stroke patients. So in ischemic stroke patients, before our paper, what was known as that, and our paper mainly focused upon the prognostication and the factors which were more associated in the patients who were transitioned to comfort care. And what was known before was that female sex, advanced age, history of atrial fibrillation, high NIH scores, complications like cerebral edema with herniation were associated with transition to comfort care. And in the past, it has also been seen that complications like hospital-acquired pneumonia in acute stroke patients has been associated with worse outcomes, not particularly like this, a transition to comfort care. So in our paper, what we found was that we studied approximately like 300 patients in 1 year, and among them, 9% of the patients were transitioned to the comfort care measures only within the same admission. And we had similarities from the previous research and data in finding that high NIH score and large territory strokes, which have cerebral edema and herniation, are more associated with comfort measures only transition. But apart from that, what we found, and is a new finding, is that and everybody can see my MRI, and we have one. This is a normal brain MRI, and this is like an insular cortex, which is kind of like a small fifth lobe of the brain, apart from the other 4 are like frontal, temporal, parietal, occipital. So we found that insular strokes in association with the other strokes were found as significantly associated in the patients who were transitioned to comfort care. And that is what we published.
Perfect. Before we move on, cutoffs for NIH stroke scale. I've read greater than 22 at about 24 hours, greater than 16 at about a week. Is that roughly what you recommend as well?
Yes, I think like that was varying in different studies, but yes, in general, we can say that high NIH score of more than 15 has been studied as mostly high in most of the studies. So
Perfect.
yeah, more than 15 was kind of like in our study too, as high.
Okay. So your paper, as you were alluding to, and we'll get into here, really highlights a novel finding, how ischemic strokes affecting the insular cortex plus a surrounding lobe was really associated with increased utilization of comfort measures only. So help us to better understand why that area is so important.
Right. So just to give a background, and I think maybe I just put an additional point here that MCA territory strokes are more associated with worse prognostication and patients being transitioned to CMO. Now, the insular cortex is supplied by an insular branch of the MCA middle cerebral artery. So here in the screen, you can see like I have two, can you see my mouse?
Yep.
Okay. So these are the MCA vessels, middle cerebral artery, and they have like an insular branch which supplies the insular cortex. But insular cortex is actually in surrounding with the frontal lobe, parietal lobe, and behind it is covered by the temporal lobe. So what we found that insular strokes, not alone, but in association with the other strokes, were having like worse outcomes and were transitioned to CMO. And this means basically that the area of the stroke is large, area of the stroke is large. And it is not only that small branch from the MCA, which is supplying the insular lobe, is causing the worst outcome. It's basically a major occlusion in the middle cerebral artery with the involvement of the insular cortex has worse outcomes. Now, to understand that more, we should know the function of the insular cortex. So insular cortex doesn't have like one particular function. It is the right insular cortex is more involved in the autonomic function. So infarction of the right insular cortex is associated more with dysautonomia and arrhythmias, which can be fatal. Whereas the left insular cortex is more involved with the language function, as the left hemisphere is mostly associated with the left, with the language function. So in general, the insular strokes, depending on the location, right or left, can have deficits in motor and sensory deficits, can have like dysautonomias and sometimes fatal arrhythmias. They can have like problems with swallowing, and dysphagia has been seen. Now, what we thought like maybe the dysphagia in turn results into aspiration pneumonia, sepsis, and that hospital-acquired, not particularly hospital-acquired pneumonia, but mainly aspiration pneumonia, and that can lead to worse outcomes. Insular cortex has also been seen to be, affecting our emotions and apathy. So our gustatory functions. So in short, we can say that solitary insular strokes do not have worse outcomes. They are generally okay. There are like some minor deficits, and patients do okay with those. But insular cortex strokes, when they are associated with the additional lobar strokes, it can be frontal, temporal, parietal, and that basically means that it is a large MCA territory strokes. It can have worse outcomes, and that is what we found. And since we are on that particular question, I want to show this slide. Like this is a normal angiogram, and this is an internal carotid artery, both sides. And this is an MCA artery, which comes out of the internal carotid, and it goes into like two branches, M1, M2, M2. This is again, like this is the left side, this is the right side. Now, if you see this picture, so this is of a patient where internal carotid artery comes, and then we don't see the middle cerebral artery. It is occluded here. So this patient will have a big right MCA stroke. And if we do a CAT scan after 6 hours, we'll probably find this picture coming out. So you see like the loss of gray white matter and this edema going on here. So and with large MCA territory strokes, the complications which we see are patients can develop hemorrhagic transformation. So we see a lot of hemorrhage here. We see herniation. We see a lot of edema. And this is these images are not of the same patient, but like of the same, right MCA stroke. So if we do an MRI, we'll see the insular cortex being involved. This is like the frontoparietal. This is the frontal, the motor cortex being involved. So multiple deficits. And such patients, basically, when they develop so much of edema, so one of the life-saving measures to treat that edema is basically to do hemicraniectomy, which means the neurosurgery kind of like it takes out this particular, a small part of the bones, and which gives the brain, to expand more, because that is the peak time. Like the first 4 to 5 days is the peak time when it happens. So these are the things which happen, and yeah. So that's what the point is.
Perfect.
Like the large MCA territory strokes, yeah, poor prognosis, especially if the insular cortex is involved.
Yeah. Why is it that it's so important that the surrounding lobes are also impacted compared to just an isolated insular cortex? And does it matter how many of the surrounding lobes are affected?
So first question, does it matter like if the surrounding lobes are affected? Yes, because solitary insular strokes are not known to cause major worse outcomes.
Yeah.
Second question, how many? So in our study, we found like most of the patients had either 1 or 2 associated lobar stroke territories. It could be either frontal, temporal, or could be, parietal, or could be like 2 lobes, frontoparietal or parieto-temporal or anything. So we did not study like how many lobes per se, but yeah, on review, it is like could be 1. Mostly, I think they had 1 or 2, but doesn't need to be like all the lobes or particular number of lobes.
Wonderful, thank you. So for our fourth topic, yesterday we were sort of batting around a couple of ideas, and we wanted to talk about external forces. So we know in healthcare there are quite a few external forces that really have the potential to influence us to make decisions sooner, make them faster, and these forces might impact us giving people time to see how much they can recover from these strokes. There are length of stay metrics, there's administrative pressures, there's shortages of beds. There might even be emotions from family, worried about patients suffering, even suffering temporarily, giving them time. And then for us as palliative care consultants, right, we're often not primary teams. So there may even be pressures from primary services asking us to make definitive decisions sooner. So how do you folks find that balance between giving people enough time and balancing all those external forces asking you to move faster?
Yes, I think this is a very practical and a as a daily life question, the daily life situation which we face in neuro ICUs. So yeah, nice question. I'm happy to discuss. So to deal with those situations, I think if we know few facts about how the strokes turn out to be, if we know some knowledge about that, it is easier to deal with these situations.
Mm.
So for that, I'll lay out some facts about the strokes, and I think those will probably those facts are helpful in dealing with those situations. So first thing, neuroprognostication is very challenging, and it's not an easy task in the first few days or few weeks. Given the nature of the strokes, hemorrhagic strokes, there are few hemorrhagic strokes which are non-survivable. And I want to show you an image here. So this is a subarachnoid hemorrhage, and we call it as a star of death. So when the subarachnoid blood, it kind of like occupies all the basal cisterns and all the like subarachnoid spaces around the pontine and the brainstem area. If we see that, neuroprognostication is easy. This is like very serious situation. Same thing here, like when there is a basal ganglia hemorrhage with IVH extension, we generally, when in the ICH, that is the intracranial hemorrhage cases, we have an ICH score, which is based upon the volume, the territory of the stroke, the amount of the blood volume, and the age of the patient, and there are like I think 2 other factors in that. So ICH score of 5, or I think it's the total score is 5 or 6, Dr. Nagaraj. I think you can correct me here. I think it's probably 5 or 6, and if the score is 5 or 6, then the injury is the stroke. It is a non-survivable stroke. So that is very easy to prognosticate. And we can straight away, from the ED itself, we can straight away, start the palliative care or the end of life or comfort care measure discussion. But it's not so simple in the ischemic strokes. Ischemic strokes, depending on the location and the territory, can have different deficits, can have different presentation, and will have a different course. We have to understand that first 4 or 5 days is a very critical time for the acute ischemic stroke patients, because that is the time when the risk of cerebral edema, which can lead to herniation, is the highest. So a large MCA territory stroke patient, if he survives the first 5 days, the risk of cerebral herniation and like development of edema is less, and which means that the risk of dying from the stroke per se is going to be very low after the first 5 days. So a patient who is brought in with a large MCA stroke, if survives the first 5 days, then after that, he may not die and he may survive the stroke, but with crippling deficits. He may have like a complete left hemiplegia or right hemiplegia, depending on like right and left. So what happens sometimes is that patients or some providers may see the survivability as a sign of recovery. But we have to differentiate here that when we are prognosticating and when we are dealing with the situation, what are we addressing? Are we addressing the life and death matter, or are we addressing the recovery? So that is one thing. Another thing is that, I'll give you an example. So the pontine stroke, so this is like a pontomedullary stroke. Now the amount of this, I don't have the slide of like, I think I missed the one slide which shows the total pons, like the anterior cut, but pontine strokes, even though the area is very small, but bilateral pontine strokes, which happens due to the basilar artery occlusion, the area is very small, but can lead to quadriplegia. And in those strokes, the only movement which the patient can do is just the vertical movement of the eyes. And this is known as locked-in syndrome. So if we don't know the living will of the patient, if we don't know the advanced directives from before, and sometimes the family support is also not good, it is very difficult to communicate in those patients as to what do they want. So they come in with basilar artery occlusion, we give them the TPA, we do the thrombectomy. Most of the time they are okay, but sometimes they may end up with a locked-in syndrome. And from there on, we don't know like what exactly the patient wanted, and the communication is very limited. It's very time consuming. And then there are these external forces which kind of like length of stay, getting the patient to rehab, and all these things. So and there I think like the palliative care team, the help comes in from the palliative care team to help us with the communication, the goals of care, finding the family support, because those are the things then we need in order to formulate the future course of the treatment. So what the point I would make is that it, if we know the potential deficits of the patient, both the worst case scenario and the best case scenario, and if we know, like based upon the location and the extent of the stroke, that how, what are the worst and the best case scenario, we may kind of deal with the situation of the length of stay, or how long is it better for the patient to stay in the hospital, and what are the complications we may see if we discharge him early. So like a subarachnoid patient, they have a risk of vasospasm for the first 14 days, like starts from like 4 to 14 days. So a subarachnoid patient cannot be discharged even if he's stable, like a big subarachnoid one. Even if the patient is doing well, they cannot be discharged like before that period. They have to be monitored. So these facts, if we know, we can deal with the situation. And if you guys encounter such difficulties, I think you talk to neurology or neurosurgery, and depending on that, we make a kind of like a consensus decision at that time.
Yeah, you're working together on that. Absolutely. So before, Nanda Kumar, did you have something you wanted to add? I saw you unmuted.
Yeah, so I can just add to what Varun said. So in terms of prognostication, I think as neurologists, we'll be able to make some reasonable judgment on the deficits that the patient will have based on the location of the stroke and the extent of stroke. I think the most difficult part would be like if the patient would survive to the critical period, and that might be a little more challenging, particularly with younger patients, because I usually consider the first 3 to 5 days as the most critical period, particularly with large size strokes or bleeding. Some patients do survive, and some patients might not survive this critical period, particularly if they have other associated comorbidities. And when we, and I think if we know the patient's like wishes, like if they had a living will, and that would probably help in talking to the family, particularly if patient was very clear that they did not want to have any deficits to be living with, and then if there's somewhere like the family is okay, that they were okay with some kind of deficits as an outcome, then and if the patient has a large stroke, then we will need to kind of to be an ongoing discussion on day-to-day basis, like to figure out where the patient will move. So I usually, when I have a meeting with the patient, the first day, usually I give them an overview of what to expect from the stroke, and I usually don't ask their opinion, like what decision we need to make in terms of withdrawal of care. I don't think that would be the good thing to do unless it's a very devastating one, or the patient is acutely herniating with blown pupil. That would be a different scenario. But I think we need to allow some time for the family to think and digest the situation. And I think palliative care teams have been extremely helpful in this regard, talking through the family. And it could be as simple as even going through the living will and explaining those what it means, so the patient family does not feel guilty of making decisions for the patient. It's basically they are obeying their wishes according to the living will. So.
Yeah, thank you. We've got one more topic that we'll ask before we open it up for questions. So if there are any questions, we'll have time for just maybe one or two. Use either the raise hand function or put it in the chat. Our last topic is on prognostication, which we've touched on a little bit already. And we've already shared that prognostication is challenging. It's humbling. In the internal medicine literature and also in the palliative care literature, it shows that we tend to be overly optimistic in our prognostication. How do neurologists fare with their accuracy of prognostication?
So I don't know the data, but I think it's probably younger neurologists like me may overestimate or underestimate, and experienced neurologists like Dr. Nagaraja, may have a better sense. So we were discussing it the other day, and I think it's a learning curve. So it's a learning curve which probably it is based upon experience. But again, your question is how is there a pattern? Do neurologists overestimate or underestimate? I'm not sure about that, but yeah, we can make mistakes, and situation can be humbling at some times. So it's difficult because in neurology, things go slowly, and sometimes, there may be complications which we are not seeing and happen, and everything can be off the rack. So yes, it can happen, but I think it may happen more with a younger neurologist, less with experienced ones.
All right. So,
I think,
please, Nanda Kumar. Yeah, what are your thoughts on that?
yeah. So in terms of prognostication, I think I feel it particularly challenging in when young patients are admitted with major devastating strokes, because uh, uh, if they get through the critical period, the recovery is better than compared to older people. One reason, like they don't have additional comorbidities that can impair their recovery, and they have the better ability to also recover with good inpatient rehab. So I think the most difficulty that we do encounter on a day-to-day basis is, will the patient survive through the critical period on the first 3 to 5 days? And I think at least what I tell is, like, we'll have to see on a day-to-day basis how things progress, and we update the family on how things are going, and get an idea about what the long-term plan or short-term plan for the family is, about how the patient would want to live, get their insight about what is going on, and that will help in making decisions.
I thank you for your presentation. And one of my questions is mostly regarding quality of life issues that we run into a lot with our families concerned about quality of life results for their loved one after a stroke. So I'm just wondering how you, as neurologists, if there's any particular way you discuss functional prognostication with them, and as well, if you have any specific language that you use or timelines that you inform families about regarding anticipation for recovery of functional abilities.
That's a very good question. I think we come across this commonly when we see patients with stroke. I think as neurologists, I think the most important thing that we look for, even before talking to the families, where the location of the stroke is in terms of in the brain, like what structure is affected. And that can give us a clear idea about what deficits to expect. And in terms of recovery, I think what I usually tell them is give like 2 possible scenarios, like best possible chances or the worst possible scenario, because we are trying to predict something based on what's happened today, like meaning based on the images that I have and everything. But things can change over a period of time. They can develop other complications and other, like pneumonia. The stroke by itself, as a cause of death occurs only in the first few days because of large amount of swelling in the brain or recurrence of bleeding. Those are the main reasons. But after they pass through the critical period, it's not the stroke, but it's other causes like pneumonia and other urine infections, DVT, PAs that can be fatal. So it's hard to predict what complications that they may develop, but in terms of the quality of life, it really depends on what part of the brain is affected. And it can be a small stroke, but in a very strategic location. For example, like internal capsule stroke, it could be a small, like 5mm stroke, but it affects, it can affect the entire half of the body in one side for motor strength. So that's important. And in terms of recovery, we always advocate patients to go to inpatient rehab if they qualify for that. Because that is the time where they can get maximum therapy to recover. And the more the therapy they get the first few days and weeks after the stroke, it's better for them. And the peak recovery time is probably in the first 6 months, but even after that, they continue to get better, but probably at a lower pace than they did initially. So I always tell them not to give up hope that they will not get better. And it really requires a lot of motivation from the patient also to actively participate in therapy. And that can help. Instead of, I think, probably saying this is what you would be like at this particular time, I think probably giving a certain range of what to expect might be more useful in terms of the quality of life. And some, for example, like some patients, we can clearly say they will be bedridden. Like, for example, this patient here, like who had large stroke, will most likely be bedridden if they survive through the critical period. Like the best possible scenario could be maybe they will be able to sit up in a wheelchair, but they'll still probably require kind of nutritional support with a G-tube. And people with the left-sided stroke do worse in terms of outcomes compared to right-sided strokes.
Thank you.
Thank you.
Yeah, I hear the same theme over and over with you guys, that it's focus on what are going to be the deficits, focus on the facts of the case. And from our end, talking to family about how do you feel about those deficits? How does that impact your quality of life? Where are those lines in the sand? Yeah. One last quick question, and then we'll let you go for the day. It was in the chat. Tom asks, can an M1 or an M2 be opened, and who is a candidate for that with interventional radiology?
Yeah, so like here in this picture, the M1 and M2 refers to two branches that comes off from the main segment of the middle cerebral artery. When the proximal portion of that M1 like M2 segments are occluded, it can be open. And even occlusion of one of the branch in the proximal location can cause a major stroke, because that essentially supplies at least two lobes. For example, the superior division supplies the frontal lobe and part of the insular cortex. The inferior division supplies the temporal and parietal lobe. So it's still a large area of the brain that is affected, and that people don't do well. And usually in terms of the stroke severity, they're usually, I would say, moderate to severe strokes, that is stroke scale more than 15, like if it is a left-sided stroke. So they can be devastating even if one of the branches is occluded in the proximal location, and they're candidates. But and again, at the same time, there are several things to consider. It's not just the location of the occlusion, it's also the timing from the stroke onset. If they come to the hospital more than 6 hours, then we may need to do a perfusion scan to determine if there is any salvageable tissue. So those things need to be taken into account.
Thank you. All right. Thank you, gentlemen, for your time with us today. We really appreciate it.
Thank you so much again for inviting us, and it was nice meeting to everybody.
Likewise. All right, gentlemen. Have a great weekend.
Thank you. Have a good one.
Take care.